Skill 2 for Nursing 234 is parental medications. This is found in Chapter 22 of your Perry and Potter book. You will also need Gerhardt's 2019 Intravenous medication book. It's spiral bound. If you want to pass successfully, you'll need to know how to calculate flow rates. I'll talk about that more throughout the chapter, or how fast you push an IV. And you also need a watch with a second hand and a calculator to do drug calculations, and I'll go over that also. So welcome to Skill 2, Parental Medications. To be successful in clinical with IV bolus medications, you will need to complete the following before clinical. First, you will need to calculate the lines per second for IV bolus. You'll need to check compatibility of the IV bolus or IV Piggyback medication with primary fluids, and both of these items need to be completed before giving medications in the clinical setting. When giving intravenous medications or IV medications, you need to be vigilant. You need to verify that the medications have not expired by looking at the expiration date. You need to use at least 2 patient identifiers. If you don't understand the order, you need to ask for help, either from another nurse or a physician. When preparing and giving medication, you need to use the computerized MARs. You need to use a strict aseptic technique during medication preparation and administration. So you always need to clean with, at the hospital they don't have alcohol pads, they're like alcohol pads, I can't remember the name, but you'll use those before and after administration. If those medication prep pads aren't available, you will use alcohol. You want to educate your patient. You cannot delegate IV bolus medications. You can delegate IV piggyback medications. And you want to minimize patient discomfort when giving medications. Why do we give IV medications? We give IV medications for patients who are unable to swallow, anything that may irritate the GI tract, if they have like a history of Crohn's and they need to be NPO. Used for anesthesia. It's only affected IV form or available as an IV. IV medications give precise, accurate dosing. We can monitor therapeutic blood levels, and also in emergency situations where the patient needs meds right away, we'll give them intravenous or IV form. Administering medications by IV bolus. It's also known as an IV push medication, so I may use that term throughout instead of IV bolus. It's a concentrated dose of a medication directly into a vein by way of an existing IV access. When you give them, an advantage is it's small fluid volume given instead of a large amount to reduce the risk for fluid volume overload. There is no time to correct errors when giving an IV bolus medication because it is fast acting. Advantages of using IV push or IV bolus medication is that it's rapid onset, it's prepared quickly and given over a short time, it can be titrated based on the patient's need, and you can give an accurate dose. Remember, before giving any IV medication, you need to assess the insertion site to make sure there's no edema or redness. If the IV fluids do not flow at the ordered rate, do not give them medication, because accidental injection of some medication into tissue surrounding a vein can cause pain, sloughing of tissue, or abscesses. Disadvantages: not all medications can be given IV. There's a higher risk of infusion reaction. It can lead to damage to the tissue at the injection site and end up with death possibly. Supplies for an IV bolus: you're going to need a watch with a second hand to know how fast to push on the syringe, clean gloves, an antiseptic swab, medication in the vial or ampoule and check the expiration date, and syringe and needle to draw up the medication, an IV lock, a saline flush to flush 2 to 3 mils before and after each flush. When you are at HRH, it recommends 10 mils before and 10 mils after. You're going to need your MAR and your Sharps container. If you do not bring a watch with a second hand to your skill checkoff, you will fail the skill. You will also be utilizing aseptic technique during this. When giving medication by IV bolus, you first need to calculate how fast to go over that, and I will discuss that in the next 2 slides. You want to educate the patient on the medication and side effects and verify that you have the correct patient and birth date, along with discussing the allergies. You want to clean the IV site, the extension tubing site, with aseptic technique or alcohol. You want to attach a normal saline syringe and attempt to aspirate blood. If you do not see blood, that's okay. It doesn't mean anything. Just so if you get blood, you definitely know you're in the vein. You want to flush with 10 milliliters of normal saline. You want to clean again with the aseptic technique using an alcohol swab after flushing. Allow to dry. And then you're going to inject the medication over the appropriate rate. And on the next, actually the second to next slide, I'll talk about how to calculate those and how to fast to push. This is where you're going to need your Gerhardt's IV book. After you push your medication or clean with an antiseptic swab such as alcohol, and then you're going to flush again with 10 mL of normal saline. As you're pushing this medicine and after you give any medicine IV bolus, you want to assess for therapeutic side effects. When calculating your IV bolus medication, your end goal is seconds over lines. So if you look up the medication Toradol, and it's on page 792 in the Gerhardt's book, it tells you that you can administer, one of the blue headings is rate of administration. And it says a single dose over a minimum of 15 seconds, evenly distributed over 1 to 2 minutes is preferred. So you always want to take the top number, the longest number, not the top number, the longest number. And so 2 minutes, we need to get that into seconds, so 2 times 60 is 120. So you're going to set up 120 seconds, and for 1 ml, because we're going to give 30 milligrams per milliliter, there's 1 ml in that, so you're going to have 120 seconds over 10 lines. So for the 1 ml, you have 10 lines. So 120 seconds over 10 lines, you get the number 12. And when you're pushing medicines with a second hand, you want to round up in 5-second intervals. So you want to round up to 15 seconds. And this is confusing. You need to stop by and see me if you have questions. I will have examples on the board. Here's another example. So our end goal is seconds over lines. And our sample medication is Zofran 4 milligrams, and it's available in 2 mL. So we're going to give 2 mL. And on page 988 is Zofran. And the rate of administration, according to your book, is 2 to 5 minutes as preferred. So we know we're going to have seconds over lines, so 5 minutes times 60 seconds is 300, and we know that we're going to give 10 mils, or 2 mils, sorry, 2 mils, and each mil has 5 lines, but we're going to give 2 mils, so we're going to have a total of 10 lines. So 300 divided by 10 equals 30 seconds a line. And if it's greater than 30 seconds a line, we need to dilute the medication, and I'm going to show you how to do that on the next slide. Okay, now we have a 10 ml syringe, and with each ml that is there is you have 5 lines. And our equation is seconds over lines, and I'm looking it up as I talk to you. Morphine, we're going to give 4 milligrams, and it's available in 1 ml. So morphine, your textbook, sorry, I forgot to flip to the page before I started recording. Morphine is on page 9 It looks like it starts on 9:09, but the rate of administration, it says to give IV injection a single dose over 5 minutes. So if we have 1 ml and there's 5 lines, we're going to have 300 divided by 5, which would give you 60 seconds a line. So that's too long to push that itty bitty amount over 5 minutes. So we're going to take our 1 ml of morphine and we're going to dilute it with 9 ml of normal saline because the textbook says it's safe to dilute morphine with saline. So now we've used all 10 ml on our syringe for a total of 50 lines. And we know we need to give this medicine over 5 minutes. So 5 minutes times 60 is 300 seconds. So 300 seconds over 50 lines equals 6 seconds a line. And you are going to round up to be safe so you're not pushing any medication too fast to 10 seconds a line. It'll take more than 5 minutes when you round up, but that means you're giving a safe, controlled dose of the medicine. If you have questions, please stop by my office and I will help you figure out this math. Do not wait until 8 a.m. of the day of the test. Some medications, when given IV bolus, may require dilution before administering. You need to verify with the pharmacy or agency policy before you dilute any medicine to make sure it can be diluted. You want to use the injection port of the primary IV tubing closest to the patient, and I'll show you that in the video. You want to use that watch with a second hand to administer the medication correctly, and you always want to safely check compatibility because if they have IV fluids such as normal saline with potassium mixed in, and you're giving possibly morphine that's not compatible with potassium, you could cause a chemical reaction in the IV tubing and possibly kill your patient. So when we do compatibility checks, you're going to use this Micromedic Solutions Home. You're going to click on HRH, or you're going to click on the link. The username is HRH, and the password is HRH. And then you're going to go to the tab that says Compatibility, and you're going to plug in the different medications to make sure they are compatible before mixing. If they are not compatible, you're going to have to stop the IV fluids, flush with saline, give the medication as calculated at the correct time, and then flush again with saline. This compatibility check needs to be done before clinical. If it's not, you could get a critical incident and be sent back from clinical, which would be a sad day. Unexpected outcomes of IV bolus medication is that the patient could have an adverse reaction to the medication. So you want to stop the medication and notify the healthcare provider. We talked about medications possibly being incompatible with the IV fluids. If the patient shows symptoms of infiltration or phlebitis, so remember that. Infiltration, you'll see swelling and edema. Phlebitis, you might see some redness and also some swelling. If the patient, an unexpected outcome that we don't want to happen because we're always educating our patient, is the patient is unable to explain medication information, like why are you giving them Zofran? They need to be able to verbalize that Zofran is for nausea. There will be a demonstration video of me doing an IV push. So IV push or bolus medications may be given through an existing continuous IV infusion. So when you started that primary line, it can be given through that, or it can be given intermittent through venous access, commonly called as a saline lock. And you guys discontinued those last year, and you start taking care of them, saline locks, when you're in the hospital, so you should understand them. Afterwards, you always want to document using your electronic MAR, which is great. If you withheld any medication, though, you need to document why the patient refused it and why. And if you're giving any medication that should have an automatic response, you want to chart that. So if you're giving a blood pressure IV form, in 30 minutes, you need to be reassessing that blood pressure to make sure the medication worked, not that you just gave it. The second portion of the skill is IV medications by Piggyback, Intermittent infusion sets, and Mini-Infusion pumps. And you're going to demonstrate IV piggybacks and volume control containers on your checkoff along with IV Bolus medications. IV medications by Piggyback, Intermittent infusion sets, and Mini-Infusion pumps. These are small volumes of compatible IV fluids infused over a desired period of time. When you see these, I think of IV antibiotics giving like this. We also give IV Tylenol and IV morphine or IV ibuprofen as a piggyback. They usually go over anywhere from 15 minutes to 2 hours. A piggyback is a small IV bag connected to a short tubing line that connects to the upper wide port of a primary infusion line or to an intermittent venous access such as a saline lock. You'll see this on the next slide so you can visualize it. Volume control administration sets are small containers that attach just below the primary infusion pack, and you give a set amount of hours and you can set how many mils you want in that volume control. A mini-infusion pump is a battery operated and delivery medication in small amounts of fluid with a controlled infusion time. Hannibal Regional Hospital uses them occasionally, so just be aware they're out there. We don't have any in the skills lab, so you won't be demonstrating that, but you may see them in your practice. This is an IV piggyback setup without a pump, as you can see, but notice that the IV piggyback is higher than the primary set bag, so just be aware that the piggyback tubing also is a micro drip, so 60 drops per mil. It can also have a macro drip. And the piggyback setup, the main line does not infuse when a compatible piggyback medication is infusing. The port of the primary bag contains a back check valve that automatically stops the flow of the primary infusion once the piggyback infuses flows. I'll give you a video demonstration on this, how to set it up with the electronic infusion device. And I also attached a link on a couple slides later how to do this. The volume control administration set also has other names such as Volutrol, Buretrol, and Pediatrol. You'll see this used at the pediatric unit at Blessing. And they're small containers, as you can see on the next slide, that hold 50 to 150 mils and attached just below the primary infusion bag or bottle. The set is attached and filled in a manner similar to that used with a regular IV infusion. However, the priming filling of the set is different. And you want to follow package directions, and a video will be provided and posted for you to see me doing this. The volume control container has clamps or rolly clamps right here at when you spike it into the primary IV bag and in between the IV pump that you're going to use. So be aware that these do exist. You'll attach your primary tubing into here. And I'll demonstrate that. So if you have questions, come see me. The Mini-Infusion pump is a battery operated and delivers medication in very small amounts of fluid, 5 to 60 mils within controlled infusion times using standard syringes. Attached is a link to a YouTube video. I know the pump looks Chinese or Japanese, but it is actually a very good video on how to do it. Remember, you need to apply pressure on the syringe to fill the tubing before you need to prime the tubing before you put the syringe into the pump. Typically, these pumps give medications over 30 to 60 minutes at a time. So they might need an IV antibiotic, and it comes in syringe form because pharmacy makes it, and you can program the pump to run over 1 hour. But this is a good video, and you will have test questions on this. You won't have to demonstrate it though. Equipment needed is an antiseptic swab. Adhesive tape may be needed if needed. Clean gloves, an IV pole, your medication, your MAR. You'll need your pre-filled syringe of saline to verify that your IV is placed in the correct place. IV tubing, If it's a piggyback, you'll need a pump, electronic infusion device. If you're using the volume control set, you need your Volutrol. And anything else, I think that's really all you need for all of that. And maybe a Sharps container. When giving IV medications, either piggyback or bolus, never administer IV medications through tubing that is infusing blood products or parenteral nutrition. Blood will look red. Your parenteral nutrition will look like white or yellow in color. If the IV site is saline locked when you go to give a piggyback medication, you need to clean the IV site with an alcohol swab, and you want to flush and check the patency of the IV site first with 2 to 3 mL before giving any medication. And you also want to flush after you give the medication so you clean the line. This is a great website. Once again, you probably used it hopefully on your last skill. And it shows you how to set up secondary or your IV piggyback tubing and how to program a secondary, which is your IV piggyback tubing. If the keypad gets locked, you type in KEY. I will give some examples with some medicine because you have to type in the medicine that you're going to plug in to set at a rate. So I'll set up some examples on the board for you to calculate. You have 1 week to practice with this IV pump. And because I only need it for checkoffs, and I do kind of you just need to practice twice before this week so you're ready and good to go on your secondaries or your IV piggybacks. When giving IV piggybacks, you need to remember that you need to give medications on time. These are critical meds typically that are given IV piggybacks, so you need to give them 30 minutes before or 30 minutes after the scheduled time. If it's a non-critical medication, it can give 1 to 2 hours of scheduled dose. And the patients may have multiple meds scheduled at the same time. So if you have a patient that is on a Q6 medicine, a Q8 medicine, and a Q12-hour medication, you need to talk to pharmacy about getting some of those times moved, because every 6 at midnight and they have all 3 due, you can't hang all 3 medications at the same time. So you're going to have to talk with pharmacy and see what medications they want to move. So if you have and then again it'll happen again in 24 hours that all 3 are due at the same time. And your every 6-hour and your Q12-hour medications will be due every 12 hours at the same time. And one of them is always going to be getting an antibiotic late. If this happens that you have multiple meds scheduled at the same time, you need to give the medication that is given most often first because of the increased frequency. You want to always remember to document that you gave the medication on the MAR or computer printout. You want to record intake and output of the volume given in the medication bag or the Volutrol, and you're going to clear those IV pumps every 8 hours unless it's something else. And if there's an adverse reaction to a medication the patient's receiving, you need to report that to the healthcare provider. Unexpected outcomes. If a patient develops an adverse or allergic reaction to a medicine when they're getting it intravenous piggyback or through the Volutrol or through the Mini-Infusion pump, you need to stop the medication and follow the policy for allergic reaction. And then we need to notify pharmacy if the medication does not infuse over the established time frame, so they might have to reschedule a medicine. A lot of IV antibiotics are timed, and they do vancomycin, which they draw a blood draw before, and they might draw a peak, which is the blood draw after, 4 to 5 hours after giving, whenever it's the highest in the body. So we need to notify pharmacy. Our IV sites may show signs of infiltration or phlebitis. We want to stop the infusion. We need to discontinue the old IV site and start a new IV site. And remember, when we're giving all these medications, we need to understand what medications fits the best scenario. If we need to give a medication over 5 minutes, that's great to always do the intravenous bolus because we can give that in 5 minutes and it's a quick push. Some nurses may use a mini-infusion pump for that. I wouldn't encourage it, but they may. And if a patient needs to receive a medication approximately over 30 minutes, we wouldn't want to use an IV bolus medication, but we could use a mini-infusion pump. That would be appropriate. We could use a Volutrol because it's controlled dosage. And we also could do an IV Piggyback. To give that medicine over 30 minutes, we could program the IV pump or calculate the drip factor, which I know you all love to do. Administering continuous subcutaneous medications is used for selected medications. It can be opioids, insulins, or turbinine. You will not be demonstrating this for skills check-off number 2, but you will have a few test questions from this area. When the patients can absorb 1 to 2 mils an hour of medication, but the rate of absorption is dependent on osmotic pressure than the rate of administration. Patients are able to manage their illness with the risk and expense involved with IV therapy. The patient must be educated on how to use this. The patient must be able to read and write and understand directions before you send them home with this. They're easy to operate in the home setting. A lot of diabetic patients can use insulin at home and integrate real-time continuous glucose monitoring. As you see in these pictures, the top left one shows it's placed in the abdomen. Your textbook says the new ones can go in the upper chest for opioid pain management. A lot of the insulins obviously go in the abdomen because that's where it's best absorbed. The other picture just shows like a little dressing on how it would be inserted on the right side. And so remember, if we're placing these in the abdomen, you want to avoid the pant line because it'll rub and get irritated. As a nurse caring for this, you want to do a nursing assessment and do interventions specific to the disease process. The continuous subcutaneous medication route requires a computerized pump with safety features, including lockout intervals and warning alarms. Ideally, medication pumps are individualized on the basis of the medication being delivered and the patient's needs. It uses a small 25 to 27 gauge wing butterfly needle or a Teflon cannula. The Teflon cannula is more expensive but does have less complications. You want to use the same anatomical site as either the subcutaneous injection sites that we use on injections or the upper chest. You want to rotate sites every 2 to 7 days. These are the supplies that you need for initiating a continuous subcutaneous medication. You need clean gloves, alcohol swabs or chlorhexidine to clean the site, a small gauge wing IV catheter with attached tubing, an infusion pump, a dressing, a tape. You need your MAR, and you need the medication and a syringe. And typically those syringes do come pre-filled from the pharmacy. When we discontinue the continuous medication in the subcutaneous tissue, we want to have clean gloves, sterile gauze dressing, tape, alcohol swab, and a sharps container to dispose of the needle. This is a great video of a girl demonstrating how to use her continuous subcutaneous medication device. The steps may vary from your textbook, but just be aware she knows what she's doing and she does a good job. And you won't be quizzed over it, but just be aware and watch this video. Unexpected outcomes of having a continuous subcutaneous infusion device. Patients may complain of localized pain at the insertion site. The treatment for this is to change the needle and monitor for infection. You could have potential for infection or needle dislodgement at the insertion site, so you just want to continue to monitor because it's just a potential. If a patient develops an allergic reaction, you want to stop delivering the medication and notify the healthcare provider. You want to add the allergy to the medication record. After initiating the continuous subcutaneous infusion device, you want to immediately document the medication administered in the patient's MAR. If there's opioids that need discarded, you need to follow policy to document waste. You want to record the patient's response to the medication and appearance of the site every 4 hours so it's not being neglected. And you want to report to the patient's provider any adverse side effects. Sometimes if they are getting diabetic, their insulin through this, they may have extremely high blood sugars, so they may need additional medical therapy for that. If they're in the hospital setting, stress makes your blood sugar rise, so just be aware they may be giving themselves insulin through their continuous subcutaneous device and also giving insulin sub-Q, possibly in the abdomen or the back of the arm also, depending on what their blood glucose reads. Special considerations: you want to teach your patient to wear a medical alert device. They need to carry backup batteries and medication. They need to be able to educate and explain diabetes management and pump care. They also need to know that this has a battery, so they can't go in an MRI machine. And you never want to immerse the pump in water or expose them to x-ray films. Definitely not the MRI machine because it'll suck the battery out and it might pull their stomach with them, so not good. Pediatric patients. This is great for diabetic pediatric patients. It gives them more flexibility and gives the patient responsibility for the diabetes management. But they need extensive education. Our gerontological population, they've been giving isotonic IV solutions to dehydrated older adults. They may infuse fluids such as 30 mL an hour for the first hour of therapy, and they can slowly increase the rate if they're dehydrated. I've not seen a lot of this in our area, but just be aware that it's out of that. In home care, we just need to educate. Patients may clean their site with antibacterial soap instead of alcohol and chlorhexidine to clean the insertion site. But education is key. And we made it to the end of the PowerPoint. You're going to have a 15-question quiz on September 17th. 5 of those questions will be math, so you understand how to calculate an IV bolus before doing your checkoff. Because if you can't calculate an IV bolus in your checkoff, you will also fail the skill. So remember seconds over lines. You're going to demonstrate the following the week of the September 17th through the 21st. How to use a Volutrol, do an IV Piggyback, give an IV bolus. So you're going to bring a drug book, the spiral one, so you know how it'll tell you the rate of administration, a calculator if you need it, and a second-hand watch to be successful. If you have any questions, you can always stop by my office. You can email me, or you could catch me if I'm in the lab with other students, just catch me, okay? Thanks for listening.